Good afternoon. My name is Katy Peters, and I'm an immunisation and travel health specialist nurse. And I have the pleasure of speaking with Dr. George Kassianos, CBE, today. George is the National Immunisations Lead of the Royal College of General Practitioners. And today we're going to be talking to George about the flu vaccine and the COVID vaccine. George, you're very experienced in this field, and I thought it would be helpful to share with people your view currently on the progress of the COVID vaccine and how you foresee this being rolled out across the UK, and indeed when you expect this may start and who will be prioritised.
Well, during the last pandemic in 2009, within 6 months, we had a monovalent vaccine for the pandemic virus. This time is 11 months and we haven't got a licensed vaccine. But that doesn't mean that we haven't got vaccines. In fact, we have got over 200 vaccines that are being tried, but some of them are in phase 3 and some of them are just about to actually publish their results for phase 3, in which case then in the UK, they will go to the MHRA to ask for a license, which is actually great. What we have seen with the COVID-19 is that we are using the old technologies, but also new technologies. That is very interesting for me because we're using a technology that we have never used before, the messenger RNA, whereby on the laboratory form RNA, we actually put the protein of the spike of the coronavirus, and then we inject it in a lipid globule to the arm, and that spike will actually cause the immune system to produce antibodies against it. But we don't give the virus, we don't use the virus at all. And that's the messenger RNA, and we have got companies that are actually using this, and already we have had the Moderna and the Pfizer actually report there are other companies that are using that. The other companies are using a vector, and the adenovirus is very popular. This is a chimpanzee, a monkey virus that doesn't cause disease in people. So that will carry the S protein. And we have got AstraZeneca, we have got Johnson & Johnson, we have got the Russians, the Gavalea. So very important adenovirus, but there are also other vectors, like, for example, the Chinese and the Russians are using the common cold virus to carry the S protein. The Novavax, we have just started trials in the UK, are using an insect cells plus an adjuvant to it. And when you give the adjuvant, you're hoping to actually create more antibodies. Sanofi Pasteur and GSK together have put to form a vaccine with the baculovirus that we know very well with their recombinant flu vaccine, plus the AS03 adjuvant of GSK. Again, we are using the technology. And also Merck are using the measles virus as a vector. Beyond that, we have got other companies that are using the virus itself, but they inactivate it, and Chinese are actually doing that. And also China and GSK are working together on mammalian cells culture to form virus. So new technologies, but also we're using the current technologies, and we were able to actually move very, very fast to get to where we are. And already we have got 2 vaccines, Moderna and Pfizer, that have given the interim results. In the case of Pfizer, they were going to report when they have 32 cases of COVID-19 in the study. You wouldn't know whether it's a dummy vaccine or the real vaccine. Then the FDA wanted them to have more, 64, and by the time they finished talking to each other, they had 94. And that's when we got the preliminary results. But they need to go up to 164 before they can report. Now, we had the results of Moderna. Moderna had 95 cases and in the interim results, but they need to go to 151 before they can actually put out their phase 3 results. So you can see everything is regulated. Yes, it's fast because so many companies have actually gone in to produce vaccines, and they run in parallel phase 1, phase 2, and sometimes phase 3. Instead of finishing with one, they're starting the other, and so on. So we are very lucky that our scientists have been brilliant, and we are there. It's not a light at the end of the tunnel I'm seeing. It's a floodlight. Really, the vaccine is coming.
Yeah, that's excellent. And do you think that the first vaccine that we get will be inactivated or will be a live vaccine?
It will be a messenger RNA, mRNA vaccine, because the two that have reported are that. Now, if we get the AstraZeneca one, it will be the vector adenovirus carrying the S protein.
Okay.
So I'm hoping that we will be able to give it to people who are immunosuppressed, for example, pregnant women and so on.
And there's been a lot on the news about what Pfizer's vaccine needing to be kept at very, very cold temperatures. So obviously within the UK, we keep all of our vaccines between 2 and 8. They're licensed to be kept in the fridge. How do you foresee this logistically being managed if indeed the first vaccine that becomes available to us is one of these very, having to be kept very cold?
Okay, let me take you through the 3 vaccines.
Yeah.
All 3, when they are made, they have to be between 70 to 80 degrees minus centigrade, minus. You can't touch it. You have to handle it with instruments, okay? Yeah. All 3, no difference. But then what you have in the case of the Moderna is that you can bring it down to minus 20 degrees centigrade and keep it there in the freezer. Now, minus 20 degrees is what you and I have in our home as our freezer, okay? It's about 20, 25 degrees. Once you put it in the fridge of 2 to 8 degrees, I will call it the pharmacy fridge, then it remains stable for 30 days.
Oh, okay. Okay. Yeah,
so you have got 30 days a vaccine in the fridge to give. Now, we haven't got more details. For example, once I draw it into a syringe, how long do I have before I give it? We have these details for the other 2 vaccines. So if we take now the Pfizer vaccine, it will come in a carton that has got 975 doses. And in the carton will be vials of 5. And if you remember, the government has asked the CCGs, the GPs, to form these centers, but they must be able to give 975 vaccines a week minimum. Why? Because if it was the Pfizer one, that's how many doses are in a carton. Once you put the Pfizer one now in the pharmacy fridge, then you have got 5 days to actually give the vaccine. But you need, when you're going to give it, you need to draw it in a syringe and dilute it with 0.9% sodium chloride for injection. It needs dilution. And once you dilute it, then after that, you have got a window of 6 hours to give the vaccine. Wow. The AstraZeneca one is a little bit different. It comes in 100 doses in vials of 10, or it comes in 80 doses in vials of 8. If you put it in the fridge, it can stay there for 6 months, and they're working towards 1 year. So that's splendid. Once you draw it from the vial to actually give it, then you have 4 hours to give it. So that's basically the difference between the 3 vaccines that we are hoping to get first. Maybe other vaccines, but we don't know about them.
So you and I know, working in GP surgeries and such, that giving 960 doses a week is challenging, not impossible, obviously. It's I suppose similar to the flu clinics that we run, where we see a lot of people pre-booked. But however, given the pressures on GP surgeries at the moment, What are the ideas? What are the sort of logistical ideas for how we can get these vaccines quickly to the population that need it?
Well, at the moment, the way we're thinking is that there will be roving teams which will go to nursing homes and so on. But the static ones need a good car park. They need the freezer, possibly, although they can be brought and put in the fridge, but they need the pharmacy fridge, resuscitation, everything needs to be there. And a normal surgery like mine with 21 spaces to park cannot do it, because you'll be serving a population of about 100,000 population. Now, it's up to public health, local council, and local CCG to actually change things around and allow for smaller centers, but we don't want to waste any vaccine.
No.
The one problem that we face is actually manpower. And GPs and their staff are exhausted. They have had to really change the way they work, like everybody else. Okay, but really, we haven't got. They are not the GPs they were there a year ago, so they need really help from others. And we have got a lot of other people who can really help us in this. And we have got nurses and doctors that have stopped working or retired. They may want to come back. There will be, of course, an assessment for them. And we have got locum GPs that don't have as much work as they had a year ago. So, you can always use them. Travel clinics, we have got one of the best experts in vaccinations in the travel clinics. We should be using them also, in addition to the travel clinics, for the COVID vaccination. Then the pharmacies, an amazing resource actually for this kind of thing. Then you have got junior doctors. If they haven't got the outpatients to utilize them because everything is done on the phone, then let us take junior doctors out of the hospital for specific hours to man these centers. So there are so many other professionals that can do it. Plus, the government has changed the regulations whereby other people in general practice can actually help. For example, physiotherapists. A physiotherapist can be trained to give vaccinations, but the counseling will be done by a clinician. So as the government actually pointed out recently, when we talk about general practice, it's not just GPs and GP practices. It's also these other people that are in primary care, superb resource to actually man these centers.
Yeah. And these centers, do you think they're going to be creating? I know when we do the flu season, we use local theatres, we use village halls, we use larger locations to see a large group of people. I mean, obviously, this was before we had to do social distancing. The tricky thing, I suppose, is not only what spaces will we use, but how will we get so many people through the door and vaccinated without increasing their risk of COVID infection?
Yes, my practice actually did, one of the Saturdays was in a school, and they vaccinated well over 800 people in one day.
Wow.
We're not thinking about that because the school on Saturday was not operating. We need premises that are there stable all the time, vaccinated until spring and summer. So we need to work together, CCGs, public health, local public health, and local councils. We need to work together to find the right premises and staff them.
Yeah, and am I right in thinking that the flu, the COVID vaccine, when it becomes available in mass quantities, will be given to everyone for free, or are we going to be looking at special groups?
Well, at the moment, the JCVI has decided to give us an interim order. Of course, the frontline healthcare professionals and social care professionals, obviously, we need to vaccinate them. We need to vaccinate the care homes, nursing homes, so that we can actually protect the residents. So they're the top priority. After that, you go by the highest risk, and the highest risk is age. So 80 and above, then 75 and above, then 70 and above, then 65 and above, and 60 and above.
Yeah.
But when you get to 60 and 65, you go in first for those with the chronic disease. And then, because at that point, chronic disease and age are starting to be at the same level. While above that, the age is actually the worst. And then 55 and above, and then 50 and above. And after that is the rest of the population. But at the moment, we're not doing trials really in children under the age of 18. So we don't know what's going to happen. Having said that, COVID is a disease that the adults give to children, while influenza, as you know, is a disease that is an infection that the children give to adults. So if we protect the adults from having the disease, we will protect the children.
Yeah. And we haven't seen it in the same quantities in any way in the kids, have we? And will pregnant women be included, do you think, in the first sort of phase?
We don't know, because we need to know in these studies that are just about to publish whether they had pregnant women and what was the outcome. We only know about the two vaccines from press releases. Now, you and I don't want press releases. We need the paper. And we haven't had that. So we don't actually know. Another problem we are going to face, Katy, is how long people wait after they're vaccinated.
Yes, of
with the
course.
COVID vaccine. Now, normally when we give the other vaccines, they don't wait.
No.
When you do flu, they don't wait. It's the same with the COVID vaccine. They will not wait. But if somebody has driven themselves to the center to get vaccinated and they get in their car to drive away, they need to stay in the center where they can be seen, not in their car because we can't see them. In the center, somewhere, just sit there for 15 minutes. Once 15 minutes have elapsed and you're well, off you go, you can drive home.
Yeah,
and
that's
the latest.
That's a major logistical difference, actually, because currently, as people know, there's no waiting after vaccine. So, George, how long do you think that this vaccine could last?
Well, this is actually very important, because when we actually get coronavirus infection with the common cold coronavirus, the antibodies don't last long. But what we do find is that if you get colds again and again and again in your life, you get less of those colds. On the other hand, we know that there are people who contracted SARS-CoV-1, which is SARS, back in 2003. 17 years later now, they still have active T cells.
Yeah.
So that says something. If our vaccines can do the same, then these vaccines we have will be long-lasting. But I will be happy for the time being now if they can last for a year. So we only need to give a booster every year, and hopefully it will be a booster rather than a new vaccine, because don't forget, SARS-CoV-2 virus is an RNA virus, like influenza virus. It can actually mutate, and it will only mutate if we attack it properly. And if it says that we are producing vaccines against it, one thing it could do is to actually mutate.
Yes.
But for the time being, we haven't had major mutations to need to change our vaccines. So I hope it will actually last for at least a year, possibly longer.
Yeah, and if it lasts for at least a year, then we just would include it as we do the flu vaccine program, which we're very good at now. So it would just become part of life, wouldn't it?
And we can cope with that until our wonderful scientists invent a vaccine that will produce antibodies that are long-lasting.
Yeah, exactly, which they will, I'm sure, eventually. Thank you, George. It's very, very helpful, because obviously, you hear a lot of different things from a lot of different places or sources, and having this conversation really helps clarify things. So can I ask you on your predictions for which vaccine you think might arrive in the UK first, and when we may be able to start vaccinating the most vulnerable, the frontline workers and those over 80 care homes. Can you give us a little guess on that?
Yeah, as things stand today on the 17th of November, the two vaccines we're going to have, possibly even this side of New Year, will be Pfizer and AstraZeneca. Take into consideration that AstraZeneca has not reported yet, but we're told that they're just about to report at the beginning of December. So those two, we're going to have them then. The Moderna, we've just bought 5 million doses, which will be delivered really in the spring. So it's much later. But the other two, we're going to have much earlier. We're going to start first in the very high risk people, the frontline people, and then we'll start really the population.
It's incredible, because I remember having this conversation possibly with you and others, April, May, and we were thinking there won't be a vaccine for a very long time. And there was even the question, will we be able to isolate this virus, get a vaccine? So it's really extraordinary. It's incredible that we've got this far. And in terms of the work that the scientists have done, is quite extraordinary, isn't it?
I think that what we have actually learned with COVID-19 is that we need scientists like the ones we have.
Yeah.
We need public health like the one we have. We need also production capacity for vaccines. We don't have enough. And we got the message, and we are feverishly actually building factories now and changing other premises to be able to actually formulate vaccines. But the vaccines of the future will not be that difficult to produce. If you take the messenger RNA, mRNA, is produced in the lab, so you can produce more and more of it. Now, the Pfizer one uses 100 micrograms of the material to form the vaccine. When we look at the Moderna, it only uses 30 micrograms and still gets actually superb results. So with the Moderna, you can actually formulate 3+ vaccines, where Pfizer only does one. Yeah. Then Pfizer learns that you don't need 100. You can go down with your micrograms. So we learn as we go. We need the scientists.
Yeah, I agree. Well, thank you, George. I think that's very, very useful, and we'll keep an eye on when these vaccines arrive. But I suppose that we're probably early next year for the general population for the elderly. So that's great news for all those grandparents and families who have been self-isolating pretty much since March. Yeah. It's a great thing for people to be able to get out and about again, once they've had their vaccine.
People want to go on holidays, travel again.
I know.
You can actually see how important travel is.
Yeah.
When we can't travel, we see the importance of it.
Yeah.
And therefore, I do hope our travel clinics will be very, very busy very soon.
Yeah, indeed. And they may well be able to help with the COVID injections, which is fabulous. Well, thank you, George. That's really excellent information, and maybe we'll meet again in a month or two and see where we are.
It's a pleasure to talk to you, Kate.
Thank you.
Always.
Thank you very much.